can put that one if you like.
No, sorry, I'll just speak. Okay, so welcome to our presentation on sensorineural deafness. Before we start, I was just going to give you a quick definition of the other type of deafness, which is conductive hearing loss. So as you can see on the slide, it occurs when there's a problem conducting sound waves anywhere along the route through the outer ear, tympanic membrane or middle ear. It can occur alone or with sensorineural hearing loss, which is the main focus of our presentation. And the three main causes are occlusion, infection or tympanic perforation. Okay, so sensorineural hearing loss is the type of hearing loss where the root cause lies in the vestibulocochlear nerve, the inner ear, or the central processing centres of the brain. As it says there, it's most commonly in the inner ear or the vestibulocochlear nerve. It's the most common type of hearing loss, permanent hearing loss, and the majority of sensorineural hearing loss is caused by abnormalities in the organ of Corti in the cochlea, so obviously there. So I've listed the main causes here, so congenital sort of maternal infections like rubella, toxoplasmosis and herpes. There's a couple of other, and genetic syndromes, there's a couple of other genetic causes, so lack of development or aplasia of the cochlea, and human cytomegalovirus is another of the maternal infections. Okay, so some of the main acquired causes are trauma, age, Meniere's disease, meningitis, ototoxic drugs, tumours, or excessive exposure to loud noise. So with age, it's actually called presbycusis, that's the proper name for the sensorineural hearing loss that comes in association with old age. There's some infections as well, such as measles, syphilis and mumps. And with the ototoxic drugs there, you've got aminoglycosides, so like gentamicin and loop diuretics as well. And quickly, I'm just going to talk about the presentation of sensorineural hearing loss. So it may manifest itself as a misunderstanding as to what people are saying to people, or asking them to repeat themselves. So that's the decreased ability to hear sounds. And they might also experience decreased quality of the sounds heard. So they might struggle to understand speech, or they might listen to music or watch the TV with the excessive volumes are turned up really high, and that's normally something that would be flagged up by people living with them, so partner or children or something. And now George is going to talk to you about the history.
Okay, so when taking a history from a patient who's presenting with what might look like hearing loss, some important questions there, some seem obvious. Do you have difficulty hearing? If so, what sort of sounds? Are they high-pitched sounds or low-pitched sounds which you struggle to hear? Can you have a conversation with background noise? This is a very important question when considering the psychosocial implications of hearing loss. Is it different if someone's sitting on your right-hand side or your left-hand side? Is there a sort of unilaterality to it? Also, how are they understanding you in the history taking? Can they clearly hear the questions you're asking? They misunderstand you? That might be another clue. Okay, so when you're examining a patient, you want to try and differentiate between sensorineural and conductive hearing loss. The two tests to do this are Rinne's and Weber's tests, the ones we both know. So that's Rinne's, where you hold it to the opening of the ear and it should be louder than against the mastoid process. Weber's is where you hold it to your forehead, and if it's one louder in one than the other. There's some confusing terminology in Rinne's test, and some people will say that a positive Rinne's test is when it is loud in front of the ear than on the mastoid process, and that's sort of backwards when you're comparing that other test where positive normally indicates pathology, whereas in this case positive can well indicate physiology. Weber's test again also has some confusion behind it, which is that if it's loud in one ear than the other, it doesn't necessarily tell you which ear the pathology is in, because if there's a conductive hearing loss, it will actually be louder in the ear with the conductive hearing problem, and that's due to some fairly debated quirks of sort of the physics of sound. Whereas if it's sensorineural loss, it will be louder in the unaffected ear. So that's an important thing to note. So treatment for hearing loss is mainly mechanical in nature or electrical. Hearing aids, as you can see depicted here, come in varying shapes and sizes, from the larger behind the ear or BTE hearing aids, right down to the smaller ones that sit completely in the canal and aren't really visible. And you can see those might be more desirable for patients who want to be more discreet about their hearing loss, but with the smaller size does come some trade-offs. You get a reduced sound quality because there's less space for the electrics. And also there's potential for feedback because it essentially consists of a microphone and a loudspeaker. There can be a loop, like putting a microphone next to a speaker at a concert. You get a high-pitched screeching, and that can be very annoying for patients. Cochlear implants can be given if there's a problem with the cochlea itself. It can't actually receive sound, and this involves threading an electrode into the cochlea. That's then wired to a surgically implanted receiver in the skull, which is then magnetically connected to a transmitter and a microphone that sits on the outside of the skull and sits behind the ear, just like a BTE hearing aid, and that provides a sort of mechanical hearing. Those are very expensive, tens of thousands of pounds, and are usually given unilaterally, unless you go privately. There are some surgical hearing aids known as middle ear implants, and they do something in between the two. They transmit sound from the bone through to the middle apparatus. Lastly, there are some important, an important support group in the UK for those with hearing loss. It was known as the Royal National Institute for Deaf People. It's now known as Action on Hearing Loss, and it's a lobbying group, and they do lots of things like try to influence policy, they do preventative measures, they campaign for greater awareness and more information on hearing loss, and they also provide a lot of support and communication training for those who might need to learn sign language and so on. Okay. And that concludes our talk. Thank you very much.